Hey everyone, this is Dr. Ruscio. Welcome back. Taking a number of listener questions today, which for me are always very helpful in terms of how do we take the vast amount of science, physiology, claims regarding testing, claims regarding supplements, whatever it may be, and really distill that down to where the rubber meets the road. What do you do? And thankfully, when you understand how the treatments work or what treatments are most effective, it simplifies a lot of what can be very confusing in terms of pathways, mechanisms, potential therapeutics, potential tests. The paradigm I'd like to start with is we really only have so many dietary changes, lifestyle changes, and therapeutics that have been shown to be effective, that we can use. And when we understand this, hopefully anyway, we can appreciate this paradigm wherein we don't make the mistake that we need a lab test to tell us about a diet that we could use or should use, or a natural therapeutic that we could use or should use. Because most of these, really all of these can be used without lab marker verification or guidance. Now, there's one very important distinction I want to draw. This is in the realm of functional, alternative, integrative medicine testing for gut health. What I'm not saying is if you're a gastroenterologist or a primary care provider wants you to do a test or a screening that you should shrug that off and not do it. You should. But if you're going into the realm of functional care and you are being told that, well, if we could map your microbiome, if we could assess your enzymes, look at your inflammation, your genes, quantify dysbiosis, quantify SIBO, this is where I'm hoping, if you've been following the work for a while, you're appreciating that that is a promise that severely falls short from the most reasonable and science-based perspective. That promise is an empty promise, and it likely leads to more harm than it does good. Again, because none of these test results, for the most part, there may be an exception or two, but I'm talking 90% at least. None of those test values or quantifications tell us how to better use this handful of dietary changes, lifestyle changes, or effective therapies any better. In fact, I would argue they get in the way of proper selection of therapies. And I'll give you one quick example. And this is perhaps a bit trite, but such a helpful example, at least I think. If you do a stool test, it's very likely you will see some type of dysbiosis with some components of your commensal bacteria, that these are the ones that you want, being low. And invariably, this will lead to let's increase the fiber in your diet, and perhaps let's use a prebiotic, which feed bacteria. We've discussed in the past meta-analysis data that have examined prebiotics for IBS, irritable bowel, finding no benefit. So what ends up happening is the test results, which are wildly inconsistent, by the way, tell you or inform you or encourage you to go on a therapeutic based upon the lab value. And this therapeutic has been well studied and documented to not help the very symptoms that you're looking to improve. So this is where the paradigm shift occurs toward we understand that the labs are inconsistent, not accurate, not necessary, and have really been, unfortunately, sort of forced into the care model by funding. And that happens, and I'm not blaming the labs. This is just a natural part of when there's an industry, in this case, integrative medicine. There will be different companies that have products and services they want to offer into that field. And if there's not due circumspection by the clinicians, what ends up happening is the paradigm in the field starts to become influenced by industry. And the IBS, the dysbiosis testing, and the prebiotics is a perfect example of what happens here. Now, alternatively, what you could do, what you should do, is look at, well, what randomized control trials, because we have a bunch, we have a plethora of RCTs for IBS, for IBD, for constipation, for diarrhea, for bloating, for reflux. What does the science tell us in terms of what therapies will help diarrheal type IBS, constipative type IBS, abdominal distension, abdominal pain, and then apply those to the individual, right? So to kick things off with that sort of paradigm heuristic front loaded, Joan asks, I was diagnosed with IBS. How do I know if I also have SIBO? So let's answer the question from a scientific perspective, and then I'll weave in what my clinical recommendations would be. So SIBO, or small intestinal bacterial overgrowth, as we're doing more and more research on this, the scientific community, I mean, we're seeing roughly 1/3, estimates vary from study to study, but if you average them across studies, you're seeing that roughly 1/3 of those with the symptoms of IBS have small intestinal bacterial overgrowth that causes it. This can be diagnosed by a breath test, and this breath test is validated. It is an accurate test. It's, I would say, one of the few in the realm of integrative and functional GI. There's different criteria for interpretation. I feel the best criteria are from the somewhat recent North American consensus meeting, wherein you want to see, or you need to see in order to diagnose, a rise in hydrogen, meaning you take the first point and you want to see a 20-point elevation from the baseline. So 20-point rise within 90 minutes for hydrogen will give you a positive for hydrogen. And if at any point in the test, the methane is above 10, that gives you a positive. Now, the reason why I would not encourage you to perform a SIBO breath test is, again, because only about 1/3 of those with the symptoms of IBS will have SIBO. So it's not going to be super helpful. Again, the test is accurate, but what does it tell you? How does it help you get improvement with your symptoms? The other thing here to bear in mind is the all too commonplace example. I have symptoms. I tested negative for SIBO. What do I do? People get so confused. Now, coming back to the earlier paradigm, we know that a low FODMAP diet can help with IBS symptoms irrespective of your SIBO breath test. In fact, one study looked at this and they did not find that the severity of SIBO, or just having SIBO present, predicted response to a low FODMAP diet. But what did? The level of symptoms. So the more severe someone's symptoms were, the more likely they were to respond to a low FODMAP diet. So this is just one of many, an example of why would you spend a few $100s and waste the at least 3 weeks by the time you get the test, prep for the test, do the test, send the test in, your clinician gets the test, and you have a chance to speak with your clinician. Why would you waste that at least 3 weeks, probably more like 4 to 5 weeks, when you could already be 2 weeks into a low FODMAP diet, already seeing benefit, and already having a sense of if that dietary change is going to be the right one for your gut? Now, something else that also happens here that's really unfortunate is, and this is one of like the flat earther conversations I feel at this point. Some will tell you if you have SIBO, you must avoid probiotics. And why this is so sad to me is because this is one area where we have ample study to answer this question. In fact, some data have even shown that if you have SIBO, along with the symptoms of IBS, you will respond better to probiotics than if you do not have SIBO. So you can do a breath test if you want to quantify SIBO. I laid out the criteria a moment ago. Would I recommend doing so? No. Again, always check this with your doctor or your healthcare provider. But what I would recommend is go to work applying in a stepwise fashion the therapeutics that we know due to this wonderful amassment of scientific research will improve the symptoms of IBS. And along with that, usually reduce leaky gut and just improve really anything else that may be secondary to the IBS, skin issues, sleep issues, mood issues. Elimination diet, low FODMAP diet, probiotics, a elemental diet, potentially herbal antimicrobial therapy, or antibiotic therapy. And I said a moment ago that we have diet, lifestyle, and supplemental. From a lifestyle perspective, remember, if you're not exercising, if you're not getting enough sleep, and if you're overly stressed and not doing anything to manage that, all of those are known provocators of IBS. This is where the win, the vast majority of the time, occurs, is starting to personalize these recommendations to your system, listening to the response, and then continuing to personalize. And the personalization is quite simple. You run an experiment. If it's successful, continue. If it's vastly successful, that's the only step that you need, the only trial that you need. If it's partially successful, layer on top of that another therapeutic and custom build a plan until you hit a satisfactory level of improvement, maintain there for a little bit, and then start to wean off the dietary restrictions, meaning broaden your diet, and also wean off the supplements. And this is really the magic. This is something that's taken me a career, 10 years, to figure out. The next question comes from Teresa. She asks, I have methane SIBO. I have tried antimicrobials, 2 rounds of xifaxin with neomycin, and my methane levels stayed high throughout all of it. Other than my constant bloat and some occasional bowel irregularity, I feel great. Should I keep treating SIBO? Well, there's a few things here, Teresa, that we want to probe into. Distension versus bloating is important to distinguish, in my opinion. Bloating typically means there could be the appearance of distension along with pain, discomfort, gas, pressure. Distension by itself, or distension really is a symptom by itself, which is the appearance of a pushed out abdomen. And if you see that devoid of any other symptoms, it could be something that's more muscular in nature. And when you say occasional bowel irregularity, I'm assuming that's fairly non-frequent. So the way I interpret this is it sounds like you could be more of a primary distension case rather than distension accompanied by IBS symptoms. Because if you're seeing this distension along with, again, pain, gas, discomfort, and more marked bowel irregularity, then the distension could be caused by what's going on in the gut. It could be dysbiosis, and these are just sort of proxies. I wouldn't recommend going to quantify any of these, but just to help you understand what things successful therapies could remedy. There could be dysbiosis, there could be SIBO, there could be leaky gut, there could be all three, and the right therapies will quell those symptoms. However, if there's only this distension as the primary symptom, then it's possible that the distension could be more so musculoskeletal. You might be someone, as I've drifted into to some extent, and we'll see this in the clinic also, perhaps sitting too much, perhaps imbalances in their exercise routine can lead to, and these are just rough approximations, but they'll get you there, an anterior pelvic tilt. And this can happen when the hip flexors are tight, tilts the pelvis forward, disengages the abdominal wall, and then you have this feeling of being distended. And if you stand up and sort of tip your pelvis forward, you'll see your stomach muscles disengage and your stomach pushes outward. And what can be helpful in these cases is lengthening the hip flexors, stretching. Sometimes the hip flexors are actually tight because they are weak, but irrespective, you want to add length to the hip flexors, strengthen the lower abdominals. And this can be sneaky because oftentimes people are doing what I call a psoas swing. They're doing hip flexor movements. They're doing leg lift type exercises. And they think they're doing lower abdominals, but they may actually have the lower abdominals disengaged and they're predominantly doing hip flexors. This is something I really appreciate about Paul Chek's early work, is sort of calling this out. And I think he borrowed from Vladimir Janda, Florence Kendall. But what you're looking to do is sort of a lower abdominal curl up, where you're not going to be moving your knee up. You're going to be keeping the hip, joint sort of fixed in an L. So if this is your hip and this is your legs, you're not doing this. You're doing this. Right? You want to pull the pelvis backwards. So you're thinking about, here's your pelvis, you're thinking this motion. And what I'll do is I'll go to the gym on one of those decline benches and I'll grab up here and then I'll lift my legs upward like this. But the key thing is to focus on tilting the pelvis, not swinging the legs. That helps with the lower abdominals. And then on the other side of the kinetic chain, posterior chain, glutes, and hamstrings may help with that. Now, it's also possible that this could be more internal. And there's a number of things you can bring to bear here. A low FODMAP diet, like we mentioned earlier, probiotics, elemental dieting, and antimicrobials. The fact that you have done antimicrobials and not responded diminishes the likelihood that there is SIBO dysbiosis overgrowth present. And this could be more musculoskeletal. However, if you haven't done probiotics, if you haven't used elemental dieting, if you haven't trialed a low FODMAP diet, then you should, because those therapies should be trialed before antimicrobial and antibiotic therapy, at least in my opinion. So those are a number of things to consider with the distension. The other thing to keep in mind also is, if your body weight is higher than it has been, then this could be abdominal adipose tissue. And the distension is more so from a deposition of fat than it is from there actually being a pushing outward of the abdominal wall. And it could be both. It could be you're 5 or 10 pounds heavier than you used to be, and you may have drifted into a postural imbalance, and both these things have to be addressed at the same time. Or it could be a need to try a low FODMAP, elemental, or probiotics. Okay, Teresa, hope that helps. Hey everyone, I would be super curious to hear, does this resonate? Is it helpful? Please leave a comment, like, or subscribe. Would really appreciate it and look forward to dialoguing with you in the comment section. Tom asks, I'm considering the semi-elemental diet after having SIBO for many years. I'm also currently doing the carnivore diet. I was wondering if a hybrid elemental with carnivore diet would be a solution. And Tom, in my opinion, yes, for a few different reasons. This can give you variety in your diet. It can help with ensuring you get ample carbohydrate intake, which can be a problem on the carnivore diet. And I would mix and match and see how that goes. In my experience, the carnivore diet can certainly be helpful, as can the elemental diet. Really, any diet has viability of assistance, but we should require less of that diet over time if that diet is functioning in a corrective fashion, which I'm assuming either carnivore or elemental will. If you hit roadblocks, then that's when you may want to consider these other therapies that we discuss, probiotics, the antimicrobials, maybe immunoglobulins, and of course, don't forget about lifestyle factors. If you've gone to carnivore, I'm assuming your lifestyle is probably fairly well dialed in, because that's not the easiest diet. And usually people who are doing a harder or more laborious diet will be exercising, sleeping a sufficient amount, etc. But just keep those things in mind also. Okay, Judy asks, how long can you take antimicrobials to keep SIBO away? Judy, this is a great question. And Kyle, I'll see if we can do an overlay of Kyle's case study.
But I was still having to sort of live on antimicrobials all the time. If I got off of them for too long, I felt horrible.
Was a very good example of how problematic it can be if you go right to antimicrobials and you skip over probiotics. And specifically, at least the indication I'm getting from anecdotes at the clinic, so take with a grain of salt, that triple therapy probiotic, meaning using the 3 different formulas together, and we sell them separately, but also in an all-in-one, can be the difference between seeing a flicker of improvement from probiotics or having more long-lasting improvements, which is exactly what happened in Kyle's case. He felt, paraphrasing his words, like there was something wrong with his system because he always needed repeat antimicrobials. But he wasn't nailing a more foundational layer, which was the use of probiotics. So when we got the probiotic protocol dialed in, his need for antimicrobials went down to 0. So in answer to your question, you can use antimicrobials in an ongoing fashion. However, we want to be aiming for the minimal effective therapy and the most natural therapies. So I favor diet and lifestyle first, then supplements, then medications. Within the supplements themselves, I look at things like probiotics and elemental diets first before using things like antimicrobials. And part of the reason for that, and Judy, you may have heard this if you've been following the podcast for a little while, is because we have data showing that the average clearance rate for SIBO when using probiotics is in the 50s in terms of percent. And it's about the same for rifaximin. It's about in the 50s. Looking at meta-analyses summarizing clinical trials. But if you combine probiotics with the antimicrobials, the clearance rate of SIBO goes up to 85%. So we want to start with probiotics, then potentially combine probiotics with antimicrobials. That should hopefully allow you not to need the antimicrobials in an ongoing fashion. And of course, if you're not doing low FODMAP or elemental dieting, at least periodically, these can all reduce or mitigate the need for antimicrobials in the long term. But if you've done all of those things, or you do all of those things, and you still notice a low dose of antimicrobials is helpful, or perhaps periodically, let's say you need 1 bottle of oregano, maybe at 4 pearls per day, and you do that once per quarter, I'm also totally okay with that approach. Per the usual, check these things with your healthcare provider, but no concern about longer term use of antimicrobials if you've qualified that's what your system really needs. Okay, Elliot poses the question, I have a client who has made life-changing progress with her gut health by going through the Great Innate protocol from Healthy Gut Healthy You. Well, that's awesome news. She used the antimicrobials for 4 months, and they are a key factor in keeping her bowel movements regular. When she reduces her dose, she immediately goes from having a bowel movement every day to every other day. How do you recommend we proceed? Great question. Every other day is not a problem, in my opinion, but I also understand where this question is coming from and the desire to move your bowels every day. But just to paint a perspective, I don't think you need to be moving your bowels every day. I don't think it's abnormal if you're going every other day. And if you haven't trialed a fiber supplement, I'm assuming if you've gone through the Great Innate, you have. But remember that fiber, supplementally or dietarily, can be helpful for bowel regularity. So just underscoring that in case you haven't given that a full or a robust trial. Now, what's interesting about the gut and fiber, along with prebiotic intake, is for some people, upping fiber and prebiotics will improve their regularity, meaning if they're constipated, they'll get more regular. But for some people, the opposite happens, and higher fiber, higher prebiotic actually slows them down. And this is where something like low FODMAP has utility. Again, if you've gone through the Great Innate, I'm assuming you've done this already, but there's options in the Great Innate. She may have gone onto the paleo diet and then right through to the rest of the protocol with the elemental diet, the probiotics, and so on. So if you haven't tried low FODMAP, that's also something to consider. Abdominal massage is an additional tool that I think is worth considering in cases like this. I was kind of surprised, admittedly, to see that meta-analyses summarizing clinical trials have demonstrated that abdominal self-massage can be adequate to markedly improve regularity. So that's something else to consider. And I think what's happening there is some people just need some motion into the intestinal tract. They may have a bit of scar tissue that causes these sort of inflection points where a stool can get stuck. They may have an anatomical shape where there's really tight turns, and just some motion helps sort of massage past those turns the stool. For some reason, massage may help stimulate endogenous motility. Nevertheless, the outcome data are there showing that abdominal self-massage can improve regularity. And then also, this is where something like magnesium or natural prokinetics, iberogast, motilpro, ginger might be helpful. Michael is wondering, I have been dealing with digestive symptoms that I attribute to candida for 2+ years. But after taking HCl for 2 weeks, almost all of my symptoms are gone except constipation. Do you think my symptoms were due to low stomach acid? And how can I resolve my constipation? Well, the fact that you have seen such a clear response to HCl certainly suggests that your system needs it. You can look to other contextual factors that increase the likelihood that HCl could be helpful. And these are age. The older you are, the more likely. If you're getting into your 50s, 60s, then it's more likely. If you have any diagnosed autoimmune condition, if you have any history of anemia, all of these increase the likelihood up to a max of about 50%, but certainly I would not say it's 100%. In fact, it probably averages somewhere closer to about 30. And we've done a video that's a bit more expansive on this, and I'll link to that video here if you wanted to take a deeper dive on HCl. But certainly, as we say, your body is boss. So if you've run the experiment, if there were not confounding variables occurring at the same time, then that's a pretty clear signal. For the constipation, as we've discussed throughout the conversation today, low FODMAP, probiotics, fiber, natural prokinetics, abdominal massage, and also don't forget about adequate water intake. Additionally, exercise. I'm assuming you're moving, but we do know that exercise helps to keep you regular. So all those things, Michael, hopefully will help you. Remember to periodically trial coming off of the HCl. This is a really important principle. I try to always bring it back up to the forefront, which is this sort of inverted view of therapeutics and dietary restrictions. We can be a little bit, more restrictive and heavier handed with the supplements until we hit a peak of improvement. And then we want to try to wean off of these things, broadening the diet, reducing the supplements. Why this is so important is because supplement creep is a real thing, meaning you read about one supplement and how that could be helpful, and then another. And before you know it, over time, your cupboard is full with 15, 20, 30 supplements, and you haven't gone through the exercise of qualifying if these are still needed, if they're still helping you. Paula poses the question, I am wondering if you know why my abdomen gets distended immediately after a bowel movement and eating. My GI, gastroenterologist, doesn't even know why and has exhausted everything he can do for me at this point. What could cause this, and what should I do? Well, this is where a paradigm shift can be helpful. In conventional medicine, as helpful as it is for some things, there tends to be this, we need to do testing or evaluations so we can name the problem. And in this case, we know that, as one example, there's a gastrocolic reflex, meaning when you eat, it stimulates the colon. And in those with IBS, this can lead to a number of symptoms to be provoked, including bloating. So that accounts for when you eat, and there may be a similar reflex for after a bowel movement. Now, that doesn't really, in my opinion, tell us anything helpful from a how do we fix the problem perspective. And this is the other paradigm. Alternative medicine more so looks at symptoms being downstream of a upstream root causative factor. So we care less about naming or quantifying the symptom and more about, well, what is happening that's driving this symptom? So in this case, looking at your diet and your lifestyle. Now, specifically, an elimination diet or a low FODMAP diet, both would have merit to trial because they may resolve these symptoms. And lifestyle, if you're not exercising, if you're not sleeping enough, these both can contribute to a provocation of things like bloating or an alteration of bowel movement regularity. And as we've discussed before, probiotics can be quite helpful, elemental diets can be helpful, and herbal antimicrobials. And all of this because what we're trying to do upstream is modulate a number of things, none of which I think you need to go out and test. But what could be present is leaky gut or inflammation or SIBO or dysbiosis or some combination of all of those. Or perhaps there's inflammation that's causing increased nociception, and that nociception is making you more sensitive to gas pressure. And even though your gas levels aren't high, you're more sensitive to normal levels of gas, right? But all of that physiology has to come down to a list of what you can do to start solving the problem, to start modulating your gut ecosystem upstream so that many of the downstream presenting symptoms will resolve themselves. So Paula, hopefully that helps. Anthony is wondering, I have been dealing with foul smelling gas for years. I took a TrioSmart SIBO breath test, but it was negative. Remember, I mentioned this a moment ago, where people will do a test expecting the test to have the answers. And in this case, maybe the hypothesis was, whoa, Anthony, you may have hydrogen sulfide SIBO because we know that the H2S gas has more of a putrid smell. So we got to do the SIBO breath test. And then what do you know? As we talked about a moment ago, only 1/3 of the people with symptoms will have a positive SIBO breath test. So it can be helpful, but there's a fair cadre of people for whom they're left saying, test was negative, but I still have symptoms. That's exactly what position Anthony's in. Continuing with this question, I have tried a low FODMAP diet, but it did not help. What do you think I should do next? Well, like we've been sort of developing throughout this conversation, we could get into the weeds and say, well, we've got to quantify, is it SIFO? Is it Candida? Is it dysbiosis? Might you have exocrine pancreatic insufficiency? Might you have low HCl? We need to know. And I would say that's not what we should do from a practical, clinical, reality-based perspective, but rather consider a elimination diet. You've done low FODMAP. Have you done elimination, like a paleo template as one example? Have you used probiotics? And if there is SIFO or Candida or dysbiosis or leaky gut present, we know probiotics can help with all of those. An elemental diet can help with many of those, as can herbal antimicrobials. An end phase thing to consider could be a trial, meaning after you've done all those things, trialing HCl or trialing enzymes. These are much less likely to be helpful, but as we saw a moment ago, in a select number of cases, they may be helpful. But most likely what's happening here is something is interfering with your ability to fully digest food, and or you have an overgrowth of some sort or imbalance of some sort that's leading to an excess production of gas. Now, that's getting into the weeds of naming what is driving the symptoms, but it's not telling you where that's coming from upstream, right? And this is where we present these various therapeutics to your system, and then if it's the right thing, your system will let you know by seeing a diminishment of the symptoms. Okay, and we have a audio question here from Goldberg.
I know you mentioned xylitol as being good in mouthwashes, but isn't that a potential problem for people who have IBS? Because I've read in different various places xylitol could aggravate the IBS issues.
Okay, so coming back to our prior principle of your body is boss, this is a simple answer to this question. For some people, xylitol can be problematic. For others, it's not. You can read all about how xylitol is potentially deleterious or all about how it may break down biofilms and can be helpful. At the end of the day, your body is boss. Run an experiment of not using xylitol, then trialing xylitol. And if when you bring it in, you notice symptoms get provocated, then it tells you, at least right now, your system does not well tolerate xylitol. Focus on what you can do to improve your gut health using the tools that we've outlined above, and then revisit xylitol, because it's very likely as your gut health improves, so will your tolerance. And final question by Marok. Does the elemental diet work for SIBO or dysbiosis? From a scientific perspective, we know that elemental dieting works for SIBO, impressive data for IBD, inflammatory bowel disease, data for eosinophilic esophagitis, and for RA, rheumatoid arthritis. Do we know for sure if it helps with dysbiosis and with SIBO? No, because there has been no formal study. Now, my strong suspicion is yes for both of these. Now, why is that? Well, the elemental diet you could criticize may fuel candida because of the carbohydrates. However, because the elemental diet will absorb in the first 3 feet of the 22-foot small intestine, the majority of the small intestine will not come into contact with these carbohydrates. Also bear in mind that when you go from the stomach and transition into the small intestine, that's when the chyme or the contents are the most acidic and therefore the least prone for any sort of dysbiosis or overgrowth to occur, because you have that acidic chyme coming out of the stomach. And if you just draw a line from stomach to colon, the bacterial count as well as the fungal count in the stomach is the lowest, and it's the highest at the end of the colon or the large intestine. And it gradually increases as you go down the line as there's less acid present, and it's an environment that's more conducive to bacterial and fungal overgrowth. So, because coming out of the stomach, the elemental solution, including the carbs, will absorb in the first 3 feet, and that's going to be somewhat protected by the acid, then I think it's very unlikely that elemental diets will feed candida or fungal overgrowth, with one exception. If someone has suspected nasopharyngeal candida, meaning they have fungus in the upper throat, in the nasal cavity, then this is where drinking things like sugars, sugar-sweetened beverages, consuming simple sugars like bananas, consuming the elemental diet may flare those situations. So that would be the one exception. So unless you're having things like a lot of throat clearing, a lot of mucus up here, then I would not be worried about it if you're thinking you have small intestinal or colonic candida or fungus. And the same exact rules apply for dysbiosis. Dysbiosis certainly will occur in the small intestine, but because it's more likely to occur mid toward the end of the small intestine and not in that first 3 feet, then we should see a favorable impact from the elemental diet because, again, the contents absorb in the first 3-ish feet, and that allows the remaining 19 feet of your small intestine to rest and repair. And this is why we see things like reduction of symptoms, a reduction of inflammation, and even improvements in some autoimmune conditions like RA. So we don't know for sure, but due to all of those factors, it's likely to help. And also remember that when you give that 19 feet, remember the first 3 it'll absorb, total length 22 feet, so the remaining 19 feet are going to have a chance to rest. This can also be immunomodulatory, meaning if part of your symptoms are coming from an immune response where there's gut leakage, then that has a chance to calm down, heal, repair, and reduce some of what might be inflammatory and immune in nature, which is driving your symptoms. So, Marok, hopefully that helps. And hopefully everyone, this conversation has been helpful in seeing a number of things, but most namely that even though you can read all sorts of things, erythritol is bad, there could be some sort of hydrogen sulfide SIBO, but my breath test is negative. I shouldn't use, let's say, probiotics if I have SIBO. Do I have dysbiosis? At the end of the day, we have a handful of tools in the diet, lifestyle, and therapeutic buckets that we can deploy. And this is really where we start moving the needle clinically, where we really start improving people's symptoms, is by personalizing these to the person, one step at a time, listening to your body. Remember, your body is boss, and doing more of what works, less of what doesn't. And this is how we cultivate really rich health. It's not by quantifying, well, it's the adrenals, or it's low enzyme function, or it's high bifidobacterium but low lactobacilli, or I've got inflammation. Because remember, as we've discussed in the past, we've split test some of the best stool assessments, meaning we took one stool sample, we put half of it in one lab's test kit, the other half in a different lab's test kit. We got wildly different results. Inflammation on one, candida on the other, but not on the one, right? So there was much more disagreement across tests than there was agreement. So we've got to stop treating the tests and rather looking at where do we have adequately studied dietary, lifestyle, and supplemental therapies to consider, and then go to work applying those one at a time. If you do that, firstly, you won't be worried about all the things that you have wrong with you that the tests told you did, when bearing in mind that if you did a different lab test, you may not even have that thing to begin with because the lab tests are wildly inconsistent. 2, you'll be able to go right into trialing therapies and using your body's biofeedback as a barometer. 3, it'll save you time. 4, it'll save you money. So hopefully this conversation helps you take a direction or pick a direction, take action, listen to your body, and use your body's biofeedback as a guide. All right, guys, this is Dr. Ruscio. I'll talk to you next time.